afraid to eat. 1-2 hours of playtime or less on our screens is more than plenty. And let's go play outside. 1 hour! Tiger it, my turn to hide. 0 sugary drinks. Yeah, that's the healthy way to think. Every kid, every day, let's have fun the healthy way. Every kid, every day, let's have fun the healthy way. 5, 2, 1, 0.
All right, welcome everybody. I'm Jessie Kreiner from Keys for Healthy Kids, and I'd like to welcome you all to episode 4 of Project Echo for Pediatric Obesity. Today's episode is entitled Protecting Our Kids' Livers, Nutritional Implications, and Treatment of Fatty Liver Disease. This episode will be divided into 2 sessions, Session A and Session B, so that we're able to comply with all of the parameters of Project Echo. And with that, I'm going to turn it over to our host with the most, Miranda.
Hello, everyone. All right, I'm Miranda Strickland, the clinical coordinator for Keys for Healthy Kids. Today, I'm really excited. We have Dr. Jamie Jeffrey, who is the medical director for Healthy Kids Wellness and Weight Management Program and the director of Keys for Healthy Kids, and Dr. Amy Gannon, who is a consultant dietitian for Keys for Healthy Kids and the Healthy Kids Weight Management Program, and she is the undergraduate program director and assistant professor of dietetics at Marshall University. And she just recently gained her doctorate in nutrition education, so we're really excited to have her here today. So our objectives for the session for today, we're going to recognize the nutritional risk factors associated with the development with pediatric hepatic steatosis and NASH. And number 2, apply the knowledge of macronutrient composition of meals for medical nutrition therapy as a first-line treatment for pediatric hepatic steatosis. I hope I'm pronouncing that right, Amy, and NASH. And then 3, understand the importance of lifestyle interventions to prevent the progression of pediatric hepatic steatosis. That's a tongue twister, and NASH. To say too, there was a 2017 report that estimated that 9% of all children, so that's all children, and 38% of obese children had some form of liver disease, including NASH in Western countries. Okay, so now we're going to go to a case study. And I'm going to turn it over to Amy, the dietitian, to go over that case study as soon as Jessie can pull it up.
As she's pulling that up, I just want to say thank you for having me today. I've worked with Miranda and Dr. Jeffrey for many, many years, and it's just really an honor to be here and to be talking with everyone today. Let me just see what I can do. So basically, we're working with SW, who is a Caucasian male. He is 9.5 years old, and he came to Healthy Kids Clinic as a referral from Cincinnati Children's. It basically became a hardship for him to make the drive anymore. And then once we get, here we go. So just a little bit of his anthropometric data, which is important for you to know for clinicians. His height is 55.5 inches. He weighed, when he came to us, 129 pounds, and his BMI was 29.6, which comes out to the greater than the 99th percentile. Oops, we lost our slide. Or
there we go.
Equal to the percent BMI, 137%.
There we go. Okay. So the question is, what laboratory workup would you perform on this patient? So we have BMP, TSH free T4, CMP, FLP, CMP, FLP, and fasting insulin, and CMP, FLP, TSH free T4, and fasting insulin.
So clearly,
what do you guys think?
Clinician question.
So we have the choices that nobody picked, just a BMP, which is correct because we want the liver function test. So we would at least want a CMP. To be honest, we don't have enough information to know if we want to get the free T4 and TSH. But if this was a board question, the answer is actually CMP and FLP. That is what is designated, which is 18% of the people got that right. 71% of the people would also add a free T4, a TSH, and a fasting insulin. Actually, there is no current recommendation for doing fasting insulin in any of these patients. And that's a whole lecture within itself. The practice guidelines from 2007 that were recently updated in 2015, both list that screening laboratory for any patient who has a BMI greater than the 84th percentile is to do a comprehensive metabolic panel, which gives you your kidney function, your fasting blood sugar that you can diagnose pre-diabetes or diabetes with, and your LFTs, which is what we're talking about today. And the comprehensive includes an ALP-FOS, an AST, and an ALT, and then your fasting lipid profile. Is that enough? You know, because I could talk the whole hour just about
One
this.
question. So
Okay.
I want to know, so when would they order a free T4 and TSH? Do you want to just tell them that?
Sure, that would be if they were not following their growth chart. They had decreased their growth chart on height, but for a 9-year-old who has not gone through puberty yet, the height growth chart is more sensitive than actually the labs itself. So because I know the height percentile, because I know this patient, Amy and I saw this patient together years ago, and I actually still see him as a patient. He's getting ready to graduate high school and go to college.
Perfect. Thank you, Dr. Jeffrey. Over what his labs were. So these are the patient's labs.
So if we look at his labs, some things that really stuck out to me as a clinician was his total cholesterol was 213. If we break that down individually, his LDL was 135 and his HDL was 56. His triglycerides, when he came to us, were 109, but that was down almost 90 points. So they had been not 191 at Cincinnati Children's. He had a fasting glucose of 90 and an A1C of 5.5%. When we look at his LFTs, his AST was 90 and his ALT was 188. So AST 90, ALT 188.
And I'll add here that normal range is high normal range is about 35 to each of these. That's what we'll just kind of put it at. So these were significantly elevated.
So I'll give some more background on this. So the diagnosis, the medical diagnosis that he has, what was Nash or is Nash with cirrhosis, and he had very significant fibrosis. Of course, I only know this because he was our patient for a while, and he did have a biopsy. And Dr. Jeffrey will be able to distinguish Nash from hepatic steatosis, because there certainly are some distinguishing characteristics there. His other diagnoses include metabolic syndrome and obesity. And I already said a little bit of this initially when he came to Healthy Kids. His parents were waiting on a second opinion on his weight loss. He had been seen at Cincinnati Children's Hospital for 2 years already at 9.5 years old for the treatment of pediatric obesity and his liver disease. Really, his weight loss was not progressing. The drive to Cincinnati was a hardship. And so we were just a lot closer for the family. For some reason, I got it.
Okay.
So he had regular liver ultrasounds, and he did have one biopsy at Cincinnati Children's, and they confirmed that he had Nash and had significant fibrosis in the liver. Really, his behaviors at home were very strongly influenced by his mother's ability to regulate his food intake. He was oppositionally defiant, and his mother would often get very frustrated, and she would give in to his demands. He had a lot of tantrums around food. The interesting thing about this guy is that he was very active. He played a lot of baseball. He was a really active kid. He had a lot of screen time, but he was still active. You know, he wasn't a couch potato, quote unquote. But at the same time, his family spent a lot of evenings and weekends at the ballpark, and that concession stand food was just so tempting for him. He had 3 initial appointments with Healthy Kids. He followed up with our 8-week group intervention and then 7 follow-up appointments. He was followed by the psychologist for behavioral therapy, and he met with both me and Dr. Jeffrey on a one-on-one basis every time he had an appointment.
Thank you, Amy. All right, so if you can, Dr. Jeffrey, can you define for us what the difference is between non-alcoholic fatty liver disease and Nash?
His metabolic syndrome. So to tell you the difference between NAFLD, which is non-alcoholic fatty liver disease, and Nash, which is non-alcoholic steatohepatitis, we always shorten those because they're a mouthful, so it's hard for us to remember the difference. But in a nutshell, NAFLD is what it says. It's non-alcoholic fatty liver. There is fat deposition in the liver, period. You will know that by increased liver function test, as was indicated in the case. With NASH, or non-alcoholic steatohepatitis, that is actually fatty liver, accumulation of fat in the liver, and a progression of NAFLD, which now there is also inflammation causing damage to the liver. So NASH is actually that damage. And traditionally, the only way to know that was actually by biopsy, because the LFT elevation could not distinguish between NAFLD and NASH, and that's why standard of care was a liver biopsy. There are now newer technologies and liver scans that can actually pick up the degree of fibrosis, and then the end result is cirrhosis. So the fact that this 9-year-old had cirrhosis, it's a miracle that I'm still following him and he has not had a liver transplant, because by all means, he should have had a liver transplant by then with his disease starting before the age of 8. That was your answer and then some.
Thank you.
So steatohepatitis, fatty liver with inflammation leading to fibrosis, and the end result of that is cirrhosis requiring liver transplant.
Thank you. So, and how is obesity associated with fatty liver disease? Can you explain that and why we see fatty liver disease occurring more frequently?
Okay, so that has long been studied, and if you read the literature, you're going to see a lot of inconclusive data about that. If you read the new literature and you ask me, I'm going to tell you 2 words, and that's insulin resistance, because insulin resistance is the metabolic pathway that is leading to fatty liver disease. There is definitely other things that influence, which I'll get into, and I know Amy's going to talk a lot about, but the connection between obesity and fatty liver disease is insulin resistance, okay? And is that all you want me to go into now, Miranda? So that's really the underlying etiology. All those, there are other risk factors.
Okay. Yeah, that was that's what we were leading into was, so what are the risk factors of fatty liver disease?
Okay, so the risk factors of fatty liver disease are very similar to the risk factors of obesity and the risk factors of insulin resistance. So starting with the perinatal period, it's always genetics. We have identified genetic susceptibility. So you take that genetic susceptibility and put them in our food environment today, with sugary drinks being more prevalent than any fruit and vegetable availability, then bam, that's why all of a sudden we've got tons of kids with fatty liver disease. It's like it's on sale at Walmart, along with the sugary drinks and the high fructose containing foods. So genetics is definitely one of them. That's a relatively new field. The one that we've long known are small for gestational age babies, large for gestational age babies, infants of diabetic moms. All of those really are risk factors for insulin resistance and early insulin resistance. Those kids seem to be very susceptible to NAFLD and NASH.
And epigenetics too.
Right, and it is a combination of those genetics. Like we try to tease it out, nature versus nurture, and it's all of the above. What I try to do when I see a patient, and when Amy and I would see the patients together, because we actually started Healthy Kids Together 17 years ago. So we look at those individual risk factors for that one patient in front of us and try to delineate those. And when we come up with that genetic susceptibility, because everybody in their family has fatty liver and they actually know what it is, and mom was a diabetic during pregnancy, we can say this is why your child got this early at the age of 8. And one of the things that does do is alleviate that pressure, because this mom definitely felt guilty because she gave in to SW every single time he wanted something. He was really good at throwing temper tantrums, and it was just much easier to passively release resistance. So for him, it was like throwing fuel on the fire. The last thing that's also a relatively new area of research with NAFLD and Nash is the gut microbiome. And that's also how some of the food sources will tie into what Amy's going to talk about. So insulin resistance, same risk factors, right? LGA, SGA, infant to diabetic mother, definitely your genetics, gut microbiome and the bacteria in the digestion. And then I've already alluded that non-alcoholic liver disease, the direct liver toxin is fructose. Alcoholic liver disease, the direct toxin is alcohol. I'm going to say that one more time so everybody understands that. In adults, alcohol is a direct liver toxin as well as the effect on the metabolism. In pediatric NAFLD and Nash, the direct toxin is fructose.
Correct.
All right, so can you tell us, Dr. Jeffrey, how do you diagnose fatty liver disease?
By the labs. So anyone that is being worked up for an elevated BMI, an abnormal growth, and has a BMI greater than the 85th percentile, at minimum should get a comprehensive metabolic panel that includes the LFTs and a fatty liver profile. And the associations are more likely to be metabolic syndrome with a high triglycerides and a low HDL. Then if they also have acanthosis or a family history of diabetes, which these kids often do on their exam, so that's another big red flag on exam besides waist circumference, is the acanthosis on the neck, under the armpits, on the hands. Then I would add a hemoglobin A1C.
And do you have to do a biopsy on these kids?
Well, that we don't have a pediatric gastroenterologist on our call today, and that is going to differ whether you ask me as an obesity medicine specialist or you ask a pediatric gastroenterologist. The standard of care in the literature at this time, it still includes a liver biopsy. However, that is changing because of the new technology and liver scans that we have available that can identify the degree of fibrosis and inflammation.
Perfect. All right, does anybody have any questions about what we've discussed so far? If you have any questions, you can put it in the chat. Before we go to Amy, do you have anything?
I did list the sequela, long-term sequela, as far as cirrhosis and the increased chance of a need for a liver transplant. It's actually the #1 reason of liver transplants now in kids, not congenital liver disease. And that's a relatively new finding, which is quite scary. And then also liver cancer down the road.
Okay.
Right.
Which are all very serious.
So this concludes session A of episode 4. If you're joining us live, don't go anywhere. We're continuing immediately. If you're joining us via podcast, session B of episode 4 is available wherever you listen, whenever you're ready to listen. Welcome to session B of episode 4 of Project Echo for pediatric obesity. This is with your feedback. Now I'll pass you back to our fabulous PA, Miranda.
Hello, everyone. We are talking today about protecting our kids' livers, the nutritional implications and treatment of fatty liver disease. And we have Dr. Jamie Jeffrey and Amy Gannon, a dietitian, with us. So we are going to discuss with Amy about the nutritional implications of fatty liver. So Amy, can you go into some more detail about dietary risk factors?
Okay, so Dr. Jeffrey already hit the nail on the head with, excuse me, fructose being the main toxin to the liver. And I have quite a bit to say about that, but there are a couple other outliers that I think it's very important to understand. So first thing, what you're really looking at are all the inflammatory factors that come into the diet besides fructose. And in the Western diet, among those would be the ratio of omega-6 to omega-3 fatty acids. So anybody who doesn't have a background in nutritional science, omega-3 and omega-6 fatty acids are both essential fatty acids, and the American diet is really flip-flopped. So what we want to see, or I guess I should say the Western diet, what we want to see are high ratios of omega-3 and low ratios of omega-6. But what we typically see are the opposite of that. Omega-6 fatty acids are pro-inflammatory, albeit essential. We must get them through our diet. They are inflammatory. We need much smaller amounts of those. They come from foods that are typically processed through soybean oil or corn oil. Some seeds have some high omega-6, safflower oil, soybean oil, sunflower oil, corn oil, things like snack cakes, snack cookies, chips, crackers, things like that. A lot of salad dressings and mayonnaise based kinds of foods. I think most people are somewhat familiar with omega-3 fatty acids. Omega-3 are things, the essential omega-3 is ALA, but EPA and DHA are the ones that are the most anti-inflammatory, and those come from fatty fish, from flax seeds, from walnuts, from oils like canola oil, and a little bit from green leafy vegetables. So what we really want are the high intakes of those omega-3 fatty acids, particularly from foods. Also, diets that are low in vitamin E as an antioxidant and vitamin D, diets that are low in probiotics, because Dr. Jeffrey alluded to that gut junction and the importance of maintaining that gut integrity. But I think most importantly would be that high fructose corn syrup and the fructose that we see in the diet. And that's, I want to spend probably the most time talking about that. I do want it to be on people's radar, though, that you have to look at the overall picture of the inflammatory foods that are coming into the diet.
Great, thank you. So can you tell us what the role of fructose and carbohydrates have with fatty liver disease?
Well, if we look at carbohydrates, you know, when I talk with patients, I basically hold up two hands and I say it's the amount and the type. And in terms of the type, what we really are focusing on, what we should be focusing on are foods that are whole grain, foods that are high in fiber, like with fruits and vegetables. The more fiber the food it has, the better it is for blood glucose. But also the better it is for fatty liver disease. A low glycemic index food is better because it helps to maintain healthy blood glucose levels. And, you know, I teach my students that fatty liver is the manifestation of high blood sugar in the liver, basically. So the higher the carbohydrate level, the more fatty accumulation you're going to get in the gut. So we really want high fiber, healthy, whole grain vegetables and then fruits. So that's the type, right? The other type are these high sugary types of foods, foods that are high in fructose, foods that are in beverages, especially that are high in sucrose. So we want those to be low. We want to emphasize those good carbohydrate foods, but still less amount, fewer amounts of those. These high fiber foods really act as prebiotic fibers. And so those prebiotic fibers are feeding your good gut bacteria. When you get, everybody has an established gut microflora, right? We get that from birth on, and we're building that through our whole life. And so the cultured dairy that we consume, any types of fermented foods that we consume, add to our good, healthy gut bacteria. When we consume a lot of rich variety of whole grains and nuts and seeds and lots of vegetables, then we're having these prebiotic fibers that feed that good bacteria. In turn, those bacteria produce short chain fatty acids, which then maintain the gut wall integrity. So it keeps the spaces between the cells in the lining of the intestines tight, so you don't develop leaky gut. Now, if we switch to fructose as another issue, it's fructose, and mostly in the form of high fructose corn syrup, but also single fructose that is isolated and used as a sweetener, and then also glucose, sucrose. So it can be any type of sweetener that's added to foods. We oftentimes have kids come, and healthy kids, that are drinking more calories in a day than what they even need to consume. And most of that sugar comes from high fructose corn syrup. High fructose corn syrup has, through an enzymatic process, has fructose isolated and increased to a much higher concentration. And if you look at the spectrum of simple sugars, fructose is the sweetest. So fructose is sweet to begin with. And then when it's made into high fructose corn syrup, it's even sweeter. If you look at obesity rates and the rise of added sugars, both sucrose and high fructose corn syrup, they have risen at the same time. So they're a parallel rise over the past 100 years, but particularly since the 1970s, when we first started seeing high fructose corn syrup added. You can mirror the high fructose rates with obesity, diabetes, and metabolic syndrome. Fructose, specifically high fructose corn syrup. Now, we're not talking about fructose in fruits, really. Okay, so we're talking about isolated, increased high fructose corn syrup is a major component of added sugars. It's distinct from other sugars, so it doesn't act the same as other sugars. It directly causes lipogenesis in the liver. It directly causes triglyceride production. It stimulates fatty acid synthesis in the liver, and it promotes weight gain. But on the flip side, it doesn't cause an insulin secretion. It doesn't cause leptin secretion. So what researchers think is that we're bypassing these normal satiety cues. So here you have children consuming high intakes of sugary drinks, mostly, and some sugary foods, and not having satiety signals that are saying, hey, I'm full, I need to stop. Conversely, you're drinking and consuming more. Then on top of that, we have these, the inflammation that the fructose is causing. So it causes an inflammatory response in intracellular pathways through lots of different chemical production, cytokine production, stress production, but also through generation of uric acid. So fructose-induced uric acid generation is important. It causes, on a cellular level, mitochondrial stress. So you're stressing out your liver cells by basically metabolizing high fructose corn syrup. I lost my train of thought for just a second. This is challenging that dogma of a calorie is just a calorie. So no longer is a calorie is a calorie. Your liver in fatty liver disease is treating high fructose corn syrup differently than it treats the sugar in a fruit, than it treats the sugar in a honey. Now you're going to get a glycemic response from all of those, but you're not going to have the same liver fatty acid or fatty liver production as you would with high fructose corn syrup, because it's just it's a different pathway.
Thank you. That was very good, Amy.
That was very wordy. I hope it.
No, it makes sense. It was good.
So I was typing in the chat and can't type and listen, but I just want to so appreciate you bringing up that the high fructose corn syrup skips those regular steps that tell your brain you're full. Mm-hmm. Because I know that clinicians that take care of families, and the families come in and say, they're always hungry, they're always hungry, they're always hungry. This is yet another reason that they're always hungry, because if they are getting a highly ultra processed foods with fructose and drinking sugary drinks, they're getting in plenty of calories, but they're still starving. And that's because it skips that feedback loop. And that's something that we see clinically that we need to understand, so we believe our families when they tell us that their kids are still hungry.
Right.
They really are. All right. So besides fructose, are there any other dietary changes we need to emphasize?
Well, so I already mentioned consuming more whole grains, right? If you look at my plate, if you consider my plate, a normal my plate, half of the plate is comprised of fruits and vegetables. When you're treating anybody who's insulin resistant, really from the most minimal insulin resistant all the way through Nash, you want to de-emphasize carbohydrates. So you want to look at a my plate for diabetes, and half of that plate should be comprised of non-starchy vegetables. only a quarter of that plate should have a carbohydrate in any form. And that form could come from a whole grain, it can come from a fruit, or it could come from a starchy vegetable. So in the very beginning, I said, I held up two hands. It's the amount and the type. We already went over the type. So let's talk about the amount. So you want to decrease the total amount of carbohydrate that's coming in. And my plate for diabetes is the easiest way. I tell patients one choice of carbohydrate per meal. It can be a fruit, a starchy vegetable, or a whole grain, but not all three. Another thing is to look at the ratio of fat and protein in the diet. So the literature on nutritional implications in NAFLD and Nash is sparse, right? If you're a researcher and you want to do a good research project, this would be it. There's not a lot of protein literature, but we do know that protein helps to stabilize blood glucose. And in treating fatty liver, that's where it's at, right? We want to prevent those peaks and valleys. We want to keep glucose levels down because, of course, excess glucose is turned to fat. There's no other storage mechanism for glucose. So any extra glucose you have turns into a triglyceride, which ultimately gets deposited in the liver and fatty liver disease. So in addition to that, we want to look at those fats. I mentioned in the very beginning, the ratio of omega-6 to omega-3 fatty acids. It's not just omega-3 fatty acids that are important, but it's also monounsaturated fats. So monounsaturated come from things like, I give an acronym of 3, canola, olive, peanut. I also mentioned that canola was omega-3. So if you look at the fatty acid components of canola oil, it is mono and it is omega-3. So it's a win-win for those. There is no healthier oil, though, than olive oil. So olive oil is the omega-3 fatty acid. The less processed, the better. So extra virgin is going to be better. Cold pressed is even better than that. That's one problem with canola oil, is that it can be very refined and very processed if you don't know what to look for. Changing the oil content of the cooking and choosing less processed foods. So those ultra processed foods and the processed foods that contain high amounts of omega-6 fatty acids, and things like soybean oil, safflower oil, sunflower oil. Those oils do not oxidize a lot, or those oils are used, they used to be made into trans fats, but now they are used in processing because they have a longer shelf life, essentially. And so if you're consuming ultra processed foods and foods with a high shelf life, snack cakes, snack cookies, snack crackers, for example, processed donuts, tons of salad dressings that are not homemade, that's where you're going to get those high omega-6 fatty acids, which are pro-inflammatory. And that's what you want to watch out for. If you can switch to a more Mediterranean type diet, there's a lot of research, not necessarily in children, but on NAFLD in general about the Mediterranean diet. Not only because it's high in fruits and vegetables, but it's high in omega-3s. It's also very high in monounsaturated fat. If you look at that Mediterranean diet pyramid, which I don't know if that's something that we can show. I know the people listening on the podcast can't see that, but if we could show that Mediterranean diet pyramid for those of us on the
Jesse,
webinar
that's
here.
the end of the slides. If you can find it, you'll see a pyramid.
That would be really helpful, because what you see is the base of the pyramid it is higher in carbohydrate than what we would want in somebody who has fatty liver, but you do see very high intakes of fruits and vegetables and olive oil, which is a real staple of that diet. Those fruits and vegetables, though, I mean, they're not just giving you fiber, they're also giving you antioxidants. So vitamin E is very important as an antioxidant in any oxidative stress, but particularly liver stress, but also these polyphenols. So there's a lot of newer research on the Mediterranean diet and the role that polyphenols play. They really are thought to be causative in reduction of hepatic fat. So the fat that is already infiltrated into that liver, we're thinking that these high levels of polyphenols, and the research I've read are through foods, not through supplements, help to reduce that fat infiltration. So that way it doesn't go on to become fibrotic. You know, what we want, it is reversible if the fat is infiltrated, you know, that is somewhat reversible, but once it becomes infiltrated with a fibrosis, that's when you run into trouble because you can't fix it at that point. Polyphenols come from fruits and vegetables, particularly ones that have that dark blue, dark red color. So strawberries, raspberries, cranberries, blackberries, blueberries, cherries, that really dark color. Oranges and apples and peaches also have some polyphenols in those too. Olives, broccoli, asparagus, spinach, and then carrots. So some of the orange pigmented fruits and vegetables, but really the dark green and the dark blues. When you're looking at whole grains, whole grain wheat, whole grain oats, walnuts, flax seeds, pecans, the healthy nuts are going to have those polyphenols, but then also dark chocolate, also coffee. So it doesn't have to be, all fruits and vegetables, even some spices.
I happen to see wine on this pyramid.
There is wine on this pyramid. Obviously, you wouldn't want that in fatty liver disease, and you clearly wouldn't want that with children or adolescents. So, but in general, in the Mediterranean diet, wine is a very important contribution of their polyphenols and also the other antioxidants, which the name is totally escaping me. Kristen or another dietitian on here might be able to remind me of what that is. It's the name resveratrol. That's what I'm looking for, is also found in red wine. So decrease omega-6, increase omega-3s, increase monounsaturated fats, particularly through olive oil, increase antioxidants through fruits and vegetables and whole grains. One thing that a lot of people don't realize about the whole grain is if you look at the three components of the grain, the germ, the endosperm, and the bran, that endosperm, when you process a whole grain, you're processing all three parts. The endosperm has a lot of benefits to it that are not added back in. So the endosperm not only has more protein and more B vitamins and minerals, but it has vitamin E as an antioxidant. It has zinc, which is an antioxidant. It has omega-3 fatty acids. So you're getting that benefit of the whole grain, plus the fiber, plus the better glucose regulation. And that's everything you want for the whole spectrum of insulin resistance, metabolic syndrome, and fatty liver disease.
It's great. So it treats everything. Wonderful. All right, so can you, in addition to what you've already discussed, but can you go into some more detail about management of fatty liver disease and what we can do as providers for patients?
So when I think of management, and the literature leads us to the trifecta. Okay, so the trifecta, think of a pyramid. Again, what you're thinking is weight loss, healthy eating through improved diet, and physical activity. And I teach my graduate students at Marshall that the best physical activity in kids is playtime. So when kids run and play, they play tag, they play on the monkey bars, they play on the swing sets. I have little ones, they're in sports, but then when they're not in sports, they're outside playing a lot. That's the physical activity we're talking about. Of course, we want kids to have exercise. If they don't do anything else, then put them on their bike, put them on a stationary bike. But the best activity for kids is exercise, is playtime, running and playing and being a kid. And nutritional changes, of course, we want weight loss. The more the kids lose weight, getting toward a lower BMI and a healthier weight through these good nutritional changes, through the changes that we talked about in my plate, the more, or the decreased hepatic infiltration of fat that we see. So there's a correlation with weight loss and infiltration of fat in the liver. And, it's positively correlated. When weight loss goes down, also fat infiltration goes down at the same time. The last thing is the combination of these pro-inflammatory fats and high fructose corn syrup. So we know that in terms of macronutrient composition changes through MNT, part of that trifecta, okay? If kids are having a typical fast food diet, what we would call a fast food diet, there is a much more stress on the liver. So when you combine high fructose corn syrup and the beverages that kids get with fast food, plus the refined grains, plus those inflammatory fats, that is insult upon injury to the liver. So you're really having to make these dietary changes with macronutrient composition changes, decrease carbs, get rid of high fructose corn syrup, decrease overall carbs, and the carbs that people are choosing, much healthier whole grains, fruits and vegetables with fiber, increase protein a little bit, more playtime for physical activity, and then of course behavior therapy. So you don't just flip a switch and make all these changes. You have to teach people how to make the therapy. You have to teach moms and dads how to say, are you hungry or are you bored? And if you're bored, what can you do instead of eating? Hunger versus craving, looking at those behavioral therapy techniques.
Really good. And Amy is wonderful at doing that. We've worked with her a lot, and she is an excellent dietitian, very experienced in dealing with pediatric obesity. So we really value her knowledge and expertise on these topics.
Thank you.
So you're welcome. Before we go to the end of the case study to follow up with it, Amy, do you have anything else any other advice that you want to give to providers about managing these patients, or anything that we missed discussing?
I know that providers, especially physicians, you don't get the same amount of time that a dietitian has. We see far fewer people, but we have more time. You see far more people, but have less time. So if there's one thing you can do, that one thing is cut out high fructose corn syrup. You even look at things like ketchup. Look at your bread. Almost all commercially produced bread has some sort of sugar because it helps the yeast to grow the loaf of bread and it helps it to brown. So look at the ingredients. Get rid of ingredients that have high fructose corn syrup, even in bread and ketchup and spaghetti sauce, things that you would not normally think of. That's number one. Get rid of sugar sweetened beverages, 0 sugary drinks in that 5210. Then the next thing is pull up My Plate for Diabetes and emphasize only 1 carbohydrate choice per meal. Half of that plate should be filled up with non-starchy vegetables. And if parents say my kids don't like vegetables, then use your behavior strategies for that. Have kids help you.
And send them to me and Rachel.
Right.
Get them there.
Right. Have kids help you in the kitchen, help kids pick out recipes, take them shopping, all those behavioral therapy strategies that we use.
Very good. Yeah. And I think, we talk all the time about meeting the patient where they are. So if you're not eating half your plate of vegetables, at least eat a quarter, that's better than nothing. So you have to start somewhere and,
Right.
Work with them to kind of get them where they need to be, but start, sometimes it's a slow process and it's a baby step. And I think we have to acknowledge too, that it's difficult. This is not an easy thing, but
Right.
we're going to be there alongside you to help you with this. And it is possible.
Right.
So, all right, well, let's go back to the case. Right there, follow-up history. Okay, so Amy's going to tell us what happened with the follow-up history. So go ahead, Amy.
So if we look at his anthropometric data 7 months later, okay, so we went from like September to March or something like that. His height was relatively the same. It was 55.5 inches. He did have a weight loss of 10.3 pounds. So his weight now is 119.5, which brings him to a BMI of 26.6. If we look at his labs, he had a further significant decrease in cholesterol, which was originally 213. He went down to 136. His LDL decreased to 76. So now that's within normal limits. Unfortunately, his HDL also increased. So his HDL went down. That's one that's pretty hard to keep high. And so when his LDL went down, his HDL went down to 41. His triglycerides continued to go down. So if you remember from Cincinnati Children's, they presented at 191. And by the time we saw him 7 months later, they were down to 93. Fasting glucose was down to 84 and a significant reduction in hemoglobin A1C. That was wonderful news. So it went down to 4.8%. So that was really good news. His liver enzymes, his LFTs also went down. So what we saw was his AST in March went to 55 and his ALT went to 111. But if we fast forwarded again 6 more months, they were down to within normal limits. So by March, in 7 months, they were still 55 and 111. If you remember, Dr. Jeffrey said the cutoff for both of those is roughly 35, a little bit higher, give or take. So if we went forward 6 more months, though, we were at within normal limits for those liver function tests, which is the best. I mean, that's the best case scenario. Now, he still had infiltration of fibrosis, but having those LFTs within normal limits shows you that those macronutrient composition changes work. Playtime works. Behavior therapy works. It's not easy work, but it does work.
Great. Thank you. Yeah, that was really interesting to see. And that just shows the impact that whenever they have the interventions and they're willing to do it. That's another thing, is that patient has to be willing to make those changes, but that it can be effective. and we can see their labs change and improve.
What we ultimately saw in this child was that when we did his initial intake in August, he weighed close to 130 pounds. By the time we saw him January the following year, like a year and a half later, he only lost down to about 124 pounds, but he had grown. And more significantly, he lost inches from his waist. And even more significantly than that, his LFTs were within normal limits. So it is about weight loss, but there is a corresponding change in weight loss and improvement in liver function test. But at the same time, waist circumference is important and LFT change is also important. Growth.
And I'll just add there as well from what Amy said, that it is that specifically the waist circumference is going to mirror those improvement in labs more than anything else, right? Because with the waist circumference, we know they're losing the visceral fat, which is also an indication of the amount of fat in the liver, and the more fat in the liver, again, we don't want them to go along that spectrum. I will tell you that the adult literature tells us that about a 5% reduction in weight will lead to metabolic improvement. The kids that have fibrosis or Nash, like this kid did, is going to have to get more to that 10% loss. And again, weight circumference and following with body composition and actually knowing fat, weight versus skeletal muscle, and looking at that, which his body composition changed. The weight doesn't tell the story, right? Because he was 9 when we saw him. If you look, his BMI went from almost 30 down to 26, and he had almost lost 5 inches in his waist. Now, just think about yourself. If you lost 5 inches in your waist.
I would be so happy.
Yeah, I would take 2, baby, right?
Right.
Right.
Anything.
Exactly.
So we have a question. The question is, what efforts are occurring in West Virginia schools to limit use of foods with high fructose corn syrup? Do you, either one of you, know anything about that? Or maybe Angela does, because she's a school nurse. I saw her on here. So if anybody has any input about that. Angela, if you want to put it in the chat.
I can give a stab, Amy, unless you know more updated.
No, please go ahead.
Okay. So the healthy hunger, so they're not doing anything specifically to address high fructose corn syrup. They have, with the Healthy Hunger Free Act, increased the amount of, before COVID, because now there's all these waivers. But the 2 things related to insulin resistance and related to fatty liver disease, NAFLD and Nash, is they have increased fresh fruits and vegetables. At one point, we're on the track to get to 100% whole grains instead of half whole grains. Again, that's backslid some because of the availability during COVID. The other thing is they were limiting ketchup. A lot of the ketchup and condiments start with high fructose corn syrup. That was not only done because of the high fructose corn syrup, but because of the sodium in the diet. So there definitely have been things that have happened with the remakeover of school foods that were better, but have since slid because of waivers at the USD level because of COVID.
Okay, thank you. And if you guys see, so Jesse put that talks about nutritional aspects of non-alcoholic fatty liver disease in obese children and adolescents, a role for nutrition. So that is an article from the European Journal of Clinical Nutrition that has lots of information about fatty liver if you want to find out some more information about it.
It's a really good article. I would suggest reading it as a follow-up.
And the other thing I want to add about the school, don't forget, for the practitioners on the call, is that you can write a special dietary form to the school, so that if the school has a waiver and is serving 50% whole grain, you can request for that patient with Nash, because of the Nash, to not have apple juice, which a lot of which has high fructose corn syrup in it, to not have I mean, you essentially treat the high fructose corn syrup as an allergy. So what you would write for a peanut allergy patient is what you would write for a NASH patient. So you would want to write to 1 starchy vegetable per meal and increase that with your fresh fruits and vegetables, and also no drinks, no sugary drinks, and to make sure they have 100% whole grains.
Yes, and she does that a lot with healthy kids. So yes, it is definitely something that you guys can do.
So I have another question, Amy, that
Okay.
I'm too, Dr. Gannon, I'm sorry, that I'm too lazy to put in the chat box, but you had mentioned that a lot of the polyphenols and other things that you can get in fresh fruits and vegetables are much better to get from that way, including fiber and that. What about fish oil?
Well, I always put this back on the physician and kids, how much fish oil do you want kids to take and a supplement? And with fish oil, the problem with the supplement is sometimes you burp up fish. So, you really want to look for one that you don't burp up fish on, first of all. You want to look for one where those fats have not been oxidized. So sometimes the fish that are farmed or fished come from, Nordic areas. They're sent to China to be processed, then sent to the US. And so in that amount of time, they oxidize, they break down, they become inflammatory. So you want to find a really good quality supplement that's being caught and processed in the same area so you don't have that lag time. I mean, ideally, you want to get your omega-3 fatty acids from food. Eat fish, eat 8 ounces of seafood in a week. So what we're talking about are fish that swim in cold waters, rivers, and oceans: salmon, mackerel, herring, sardines, and tuna. Not albacore tuna. Albacore tuna is high in mercury. So regular canned or pouched light tuna is the best one, but also flax seeds, also walnuts, also canola oil. Walnuts and canola oil are high in ALA, which is an omega-3, which is converted to EPA and DHA at a much lower rate. So if you can get it in fish, that's the number one thing. Actually, brook trout in West Virginia swims in our cold streams. That's going to have some omega-3 fatty acids in it, but salmon, mackerel, herring, tuna, sardines especially.
So we have a couple questions. First, I'm curious, Amy, because I know you eat fish, where they buy it. Somebody asked about fresh fish. And then also they said, what if someone will not eat fish? What would you recommend?
If somebody would not eat fish, I would explore using canola oil to bake and or cook with. I always say olive oil to cook, canola oil to bake. Increase walnuts. And if you can get somebody to incorporate flaxseed meal, not the seeds themselves, but ground into meal, because the seeds are indigestible, use the flaxseed meal. But that's at the point where you want to ask the doc about a supplement, and if this child has a really high ratio of omega-6, you want to cut out those foods and then slowly increase. But I would treat that fish like other foods, work to see, give a consult to a dietitian, see if there are some recipe changes they can make, trying new things. I find that a lot of kids will be more acceptable of fish if they eat it in a recipe, if they change a little bit at a time, like a fish taco, for example. That's a great way to try fish, not just a piece of fish on the plate. There are other foods, but there's not as many other good sources of the omega-3, of the DHA and the EPA, particularly the DHA, which tends to be the most anti-inflammatory.
And where do you get your fish?
Oh, okay. So my favorite salmon is from Aldi. Personally, I really like the Aldi salmon.
Say that. I know he loves Aldi.
My backup salmon is from Kroger, but it's not as fresh. So my favorite fish actually is from Aldi. That's where I buy my salmon.
We do too, from Aldi. Every once in a while from Sam's, but the Aldi fresh.
Once in a while, Sam's. The problem with Sam's is, you have a bigger family. My Sam's salmon is like that big. Aldi is
Amy,
like we can split.
I cut it up and freeze it.
Yeah, you do. Yeah. There you go. See, that's why we're
out of time. Right? But one other question, Amy, you had mentioned about buying a specific type of canola oil. So how do we tell what that specific type is?
So organic canola oil is the best to buy because it's less refined. So canola oil comes from the rapeseed. So it takes a lot of energy to press that seed and get that oil out. So if you buy canola oil, which is organic, it's a lot more expensive, but it's worth it for the refinement. Olive oil, if you buy extra virgin, they're using, that's the first pressing of that olive, and it's less refined too. Olive oil generally is a pretty healthy oil. You're just not going to have that omega-3 component like you would with canola oil. Now, I will tell you, a lot of people disagree with me on the canola oil. I stand firm in my canola recommendation. And I'm a lipid girl. I know a lot about lipids, but a lot of people disagree with me on canola. They think it's too refined. I think that's less important than the anti-inflammatory benefits of the omega-3s.
Okay. Well, thank you. This has been wonderful. You guys have given us so many helpful tips and information, and I really appreciate you being here with us. We are unfortunately out of time, so I'm going to turn it over to Jessie to close us out. Thank you for being here.
You're welcome. Thank you for having me.
Yeah, that was awesome, Amy. I'm actually going to have to go back and listen to this again when I'm not running tech, because there was so much to learn and I really enjoyed it. All right, so this concludes our session. Back here in about a month.
5, 2, 1, 0. Every kid, every day. Let's have fun the healthy way. 1, 2, 3, 4, 5 servings. Fruit and veggies are great to eat. 1-2 hours of playtime or less on our screens is more than plenty. And let's go play outside. 1 hour! Tiger it, my turn to hide. 0 sugary drinks. Yeah, that's the healthy way to think. Every kid, every day. Let's have fun the healthy way. Every kid, every day. Let's have fun the healthy way. 5, 2, 1, 0.
Bye, everybody.